speaker, now I invite Dr. Rajiv Yeravdekar, Dean, Faculty and Faculty of Health and Biomedical Sciences, Symbiosis Institute of Health Sciences, Pune.
Good morning, everyone. Before they set up the laptop or the presentation, I must take this opportunity to reiterate what my friend Mr. Dr. Dilip Sada just said. And there are two issues which the IMA has been spearheading, and as a former member of the Board of Governors at the Medical Council of India and a sitting member of the Maharashtra Medical Council. Ethics at the Maharashtra Medical Council is something very, very near and dear to us, and we are particularly passionate about ethics. And so this practice of debarring and deregistering people, doctors who are engaged in cut practice, and the recent amendments to the IT Tribunal Act, which prohibits acceptance of freebies to the medical practitioners, is something worth considering. And let me also reiterate on this platform the stand taken by the Maharashtra Medical Council as regards the action to be taken against defaulters as regards the PCPNDT Act. And Madam Lochan, it would primarily please you to understand that Maharashtra leads in the number of convictions or cases against PCPNDT, and in Maharashtra Pune leads. So what Maharashtra thinks tomorrow, probably Pune thinks today. That's what the saying goes. So on this August platform, we would reiterate the Pune population stand, and particularly the medical fraternity spearheaded by the IMA in reiterating the policies of the public health, both at the center and the state. Distinguished panel, jury members, and my dear friends, I will be today talking on a topic of about healthcare transformation as how I perceive it, predominantly from an academic standpoint of view, but also incorporating my experiences at the Medical Council of India, the Maharashtra Medical Council, and the Maharashtra Nursing Council, and the recently initiated efforts of the government of Maharashtra as a subset of the National Skill Development, the Health Sector Skill Council, of which we are members, which engages in skill development and capacity building. More about it as I come to it subsequently. And how does this go? So we're talking about, is this correct? Okay. That's Maharashtra with all its districts, and no need of elaborating further on the diversity and the variations in the topography of the state of Maharashtra. And we come to an analysis or a look at the healthcare statistics pertaining to Maharashtra. This I am projecting into this learned audience at risk, because I need not reiterate the statistics with which the audience would be familiar, but the idea is to link it to the public health policies and the initiatives of the government of Maharashtra. And we're talking about manpower. We see that the total number of doctors in the state registered would be 1,58,000. This is as per their statistics on the website. Now the interesting thing is the number of allopath doctors and the non-allopaths, the Ayurvedic doctors, the BHMS doctors, the Unani doctors, and maybe there's some other pathy which is also practicing or which we are not aware of. The distribution is equal. The number of doctors are equal. But if you go to a small place called Wagoli, which is about 15 kilometers from here, those who are in Pune, from Pune would know, 15 kilometers from Pune, the scenario is totally different. You will not see or hardly see one or two MBBS doctors, but for every one MBBS doctor, and we did this as a survey from the Symbiosis Institute of Health Sciences, the number of ratio of allopath doctors to non-allopath doctors, for every one qualified registered medical MBBS doctor, there are about close to 14 non-allopath doctors, sir. So as I always say in every August forum, MBBS is the extinct species. I'm sorry to say that. Because today's MBBS doctor is either studying for his PG exam or is 1 foot out for USMLE or for the RCOG exams in the UK, or anything. He does not believe in this concept of family physician, and no harm done for the non-allopaths. These are the ones who are venturing out into the periphery, and that probably substantiate the stand. And I'm no proponent and mouthpiece of the government as Madam Lochan, but probably substantiates the stand of the government in allowing homeopaths to take a 1-year program and then practice modern medicine. I know the IMA is opposing it. I will not get into that controversy. I am also a member of the IMA. Stepping onto that foot right now. But that probably substantiates why the government of Maharashtra thinks it's worthwhile to invest in non-allopathic doctors, because the ground reality is we don't have MBBS doctors, especially in the periphery. The total number of nurses registered are 59,000, and we talk about a demand-supply ratio. We always say that nurses are in tremendous shortage, so we should be starting more nursing colleges. But today, at least in Pune city, there are 4 to 5 nursing colleges, and none of these nursing colleges have a cent percent enrollment for the BSc program. None of these colleges. It includes my nursing college at Symbiosis. So there is the Demi Grant Institute, there is Bharati Vidyapit, there is Deccan Education Society. None of them have a full enrollment for the BSc nursing courses. Not this year, but the couple of years preceding that. Hopefully the picture should improve next year. And we talk about registered pharmacists. Now, we're talking about doctors, nurses, but does the Indian Medical Council or the IMA or the MCI statute have the word paramedic defined? I'm sorry, to the best of my knowledge, the word paramedic is not defined. A registered medical practitioner is defined. Who can and who is the registered medical practitioner? But do we have defined who is the paramedic? Is it a nurse? Is it a pharmacist? Is it a physiotherapist? Are the lab technologists paramedics? Who are they? No, it's not defined, and the physiotherapists choose to have a separate council of their own. The pharmacy has got a separate apex regulatory body. So this is where the dichotomy or the discrepancy is as regards to manpower. The next dichotomy about the status is about the healthcare infrastructure. And these are the statistics about how many primary healthcare centers are there, how many district hospitals are there, how many sub-centers are there, how many are catering to the rural population, how many are catering to the urban population. The multi-speciality and super-speciality hospital, and the Honorable Health Minister Mr. Shetty has gone on record and saying that he would envisage more number of multi-speciality and super-speciality hospitals. He was recently in the city at the hospital and inaugurated the multi-speciality wing part of it, which had all the CT scan and MRI facilities. Very commendable effort. But the important thing is they are also setting up women's hospitals, and when we come to the Janani Suraksha Yojana, and I talk about this with particular passion as a gynecologist, is Janani Suraksha Yojana, I don't have the statistics, I don't know how successful it has been implemented in Maharashtra. The national scenario is none too encouraging. We're talking about the budgetary provisions in the state of Maharashtra, and I'm glad to see the arrow, if not horizontal, at least it's an oblique one. We are trying to shift it with what they call as a curve to the left. It talks about the healthcare expenditure of the government of Maharashtra. And when we are talking about the healthcare expenditure and the budgetary allocation, the GSDP of Maharashtra was 11 crores 99 lakhs 458 last year, and we are projecting a cumulative aggregated growth rate of 7.5. It is slated to be 13 crores. Now, as per WHO statistics, it should be 5%. Any progressive society would have 5% of its allocation. But unfortunately, this is not the case, where the budgetary health allocation for healthcare sector is 65,000 crores. And with this, the total expenditure is 7,400 crores, which comes to less than 1%. But now, is Maharashtra the deviant, or is Maharashtra the black sheep in the entire national scenario? No, because on a national platform, we spend less than 1%, close to 0.9% of the public healthcare spending is. So Maharashtra is very nationalist or patriotic, and so it does not want to probably deviate from the national standards. But this is where a progressive state like Maharashtra should think of different strategies. With the result, you have the following statistics of the healthcare parameters in the state of Maharashtra as depicted on the website. And as a progressive state, we as Maharashtrians and we as Punekars specifically would like these statistics to improve. And we're talking right from womb to tomb care, and that's why I put antenatal care or care during pregnancy as the first step and the death rate as the last. So these statistics need to improve. And from public health perspective, we would particularly interest Madam Lochan is the toilets and the clean drinking water. And Just a couple of weeks before, we had an initiative from the Pune International Center headed by Yeravdekar sir, where we're talking about setting up disposable toilets and the portable toilets, and especially in the rural area, especially for the women where social inhibitions play a major role. So how do we look at this concept of transforming the hospitals and particularly healthcare delivery in the state of Maharashtra? A prelude would be to having understood these statistics and these parameters. What is the landscape? What are the roadblocks? What are the challenges? What analysis of what we probably need to address? We all talked, and Dr. Kala very eloquently expressed about the accountable part of the 4 A's. When I say 4 A's and 3 E's, it is predominantly accessibility, availability, affordability, accountability, equity, economical, and so on. And Kala sir was particularly emphatic on the accountable type of healthcare. Madam Lojan also spoke about the accountability as regards the doctors as to documentation. Now this is something which we need to understand, that this is something which we need to address. The second is lack of infrastructure status to the healthcare sector. This is something which we are, through the FICCI, of which I am a member, and the CII, trying to discuss with the government. Can the healthcare sector be given an infrastructure status? And at the risk of imparting some knowledge to this learned audience, infrastructure status would be economical heaven for the healthcare industry. It would entail a lot of import-export subsidies. It would have a honeymoon period as regards the return on investments is concerned. It would encourage a lot of FDIs. So the moment you are listed as an infrastructure status ministry or a field, you get a lot of facilities and services and government concessions. So this is something which we are trying at the national level. Real estate prices, I need not elaborate, and that's the bane and burden of setting up hospitals or healthcare delivery insurance in the metros and in the A-grade cities. And an interesting concept which I would like to probably share with you all is, we all as public health experts or public health or healthcare workers talk about the triple burden of disease, the chronic diseases not being eliminated, the acute diseases being added, and a third dimension of lifestyle related diseases coming. But in the landscape of what we are discussing today, the triple burden of disease in a way correlates to the maladies of setting up or ensuring healthcare delivery. One is you need to have the investor who is willing to invest in time, energy, efforts, resources, and when I say resources, it's beyond the financial constraints. So you need to have that particular person, be it the government or the private person. Second are the regulatory environments, the hospitals, and I believe there are close to about 30 odd permissions which are required before one sets up a hospital. And the third thing, from an economic standpoint of view, is the break-even point. Typically, how long would it take for a hospital to ensure operational efficiency? People talk about 5 years, people talk about 7 years, but if you see the overall picture, it would come anywhere around about close to 7 to 10 years before a hospital can think of break-even. And if we are going to be going into the track of ensuring a break-even, there would be a strong digression from ethics, which we as healthcare professionals cannot and should not afford. That's what I was planning to get into the table. So, how do we work about it? There has to be a systems approach, and when I mean a systems approach, I mean a symbiotic approach, where it has to be the government, it has to be the private players, it has to be we as citizens, it has to be we as healthcare providers, it has to be we as regulators, it has to be we as the common man on the street to whom the impact of healthcare delivery is direct. So it has to be a shake hand approach from all stakeholders. The public health sector in Maharashtra has done a phenomenal job, wonderful job, huge number of initiatives, and just to quote one example of which with which Symbiosis is very closely associated is the launch of the Maharashtra EMS project, which was flagged off by the Honorable Chief Minister just a few months back, and talks about 937 ambulances deployed in all districts of Maharashtra, and we at Symbiosis, being the educational providers, training close to about 3,000 doctors and paramedical workers in ensuring that these ambulances across all districts of Maharashtra are well manned by trained, qualified, and most importantly, certified manpower. So this is, I think so, one of the flagship projects of the Maharashtra government, and kudos to Maharashtra government for having evolved such a very prestigious MEMS project. And I was interacting with Dr. recently, and he's the CEO of Dr. Shergate rather. He is the COO of the project and an alumnus of our program, and he said that the initial few months of the records which they have got show a very impressive call response time, reduction in the morbidity, reduction in the mortality, all comparable to the Western standards. Then there is the National Rural Health Mission, which is trying to change the landscape of the healthcare delivery, not only in the rural part, but an NUHM mission is also is operational. Not many of us are aware that akin to the National Rural Health Mission, there is a National Urban Health Mission also. And gentleman sitting on this dais, about whom we just heard, Dr. Kala, spearheading the quality and standardization efforts to the QCI and the NABH. Private sector, to which I represent, is not far behind, and we've got the major players coming in, and these major players are not only now trying, Bombay, Calcutta, Delhi, and Madras, Chennai, but they're also looking at tier 2 and tier 3 cities, where apparently, from their standpoint of view, the EBITDA margins are better, the economic delivery is better, and real estate prices are not very high. The problem faced as a private service provider, be it in the educational sector or in the healthcare sector, which we face, is the lack of trained manpower. Now, whether it's my teaching faculty at the university or whether it's doctors in the hospitals, the attitude of being loath to go to tier 2 and 3 cities is something universal across the cadre of trained and qualified manpower. This is something which we have to grapple with. But having said this, there have been certain success stories from which Maharashtra can and needs to take note of. One is there are people who are trying to revive a dying tradition. There are initiatives like the Wellspring initiatives and the Medcare and the others which are trying to promote the concept of family physician. There is Dr. Shankanu Chattopadhyay, there is Dr. Gautam Sen, who are setting up these business ventures and trying to ensure primary healthcare delivery. There is identifying the need in the public health sector, in the Rajiv Gandhi Yojana, or in the private sector, trying to tap the untapped potential, because the penetration and the density and you've got a session on health insurance in the afternoon. Sriraj Deshpande would be talking and elaborating more on it. So how can we target the health insurance delivery? Home healthcare services is an emerging market, and when we are talking about the escalating cost of healthcare, cross-infections, as was pointed out by one of the panelists, huge number of advantages, and today slated and touted to be 2 billion, it is expected to, the market of home healthcare services is expected to reach 20 billion in the next couple of years. Challenging the conventional, formerly it was believed that every surgical stay would require, every surgical intervention would require a couple of days in the hospital. There are daycare centers, the NOVA and the Primus groups investing hugely. That cuts down the operational cost, and that in fact makes the healthcare delivery more operational and affordable. And the last one is the emergence of single specialty hospitals, classically exemplified by the Vasan Healthcare and the other groups, or the Springfield hospitals in Mumbai, which talks about focusing on one single specialty. So you have got a mechanical approach, a single track, one track approach, focused approach, which cuts down and which makes the operations more SOPized, standardized, like the Arvinda Eye Care or the Narayana Hrudayalaya in Bangalore by Dr. Devi Shetty. That all adds to the quality of healthcare delivery. Now, in light of these success stories, what, in my personal opinion, could be the way forward is Panchasutri Karyakram, which I call it, and that would be starting with augmenting infrastructure. And when I say augmenting the infrastructure, there are two components. One is the quantitative augmentation, and the second and more importantly is the qualitative augmentation. Now, infrastructure is a broad generic term by which I mean resource allocation, and by resource allocation it is not only the infrastructure but also the human manpower, the human capital, materials or the means, or the monetary allocation by the government, as well as the investment by the private sector. The second one is knowledge transfer, and Ravi Gupta ji, this is an excellent forum where you are seeking to transfer knowledge or disseminate knowledge, where you are getting together different stakeholders, and it is organizations or agencies like you which get together people, share success stories, learn from our experiences, learn from our failures, and evolve a near consensus model. So this is a commendable approach. Adoption of technology is something which we need to do, whether it's information communication technology or healthcare specific technology, robotics, minimal access surgery, on which Dr. Shailesh is going to speak in the afternoon. So we should not be technology shy, we should be technology savvy. And healthcare, unfortunately, is one of the sectors which is resistant to adopt ICT. The fourth one is partnerships, collaborations, as Dr. Kalra said. Partnerships, we are all familiar with public-private partnerships. How about thinking of private-private partnerships? If I as an educational institute want to tie up with Jahangir Hospital across the road, across the city, why should the MCI insist that I need to have a hospital of my own? I can shake hands with Jahangir. Dr. Meena is here and I am here from Symbiosis. So why should we not collaborate together to set up a medical college? Why does the medical college say that the hospital and the educational medical college should be owned, managed by the same trust? Can we relook at it? Food for thought. And as an academic, finally, we need to invest on capacity building. And in capacity building, it's not the doctors, it is not the nurses. More importantly, is the skill development and vocational training which we need to give to these less in the limelight people, that is the technologists or the nurses or the pharmacists, whatever cadre you call them. But and it's through the Health Sector Skill Council at the Symbiosis, we are in sync with the National Skill Development Agenda. The former Finance Minister, Mr. Chidambaram, had pledged close to about 1,000 crore rupees for this National Skill Development Program, and the Health Sector Skill Council is evolving National Occupation Standards, NOS, by which a particular trade will have well-defined parameters of education, qualifications, experience, and the certification for the award of the title would be commensurate with that. So a hospital, whether it's Ruby, Jahangir, Metro, Fortis, knows exactly what trade, what designation, what cadre of people they are employing, what salary they need to pay. There is standardization of services and quality standards are ensured. So that pleases Dr. Kalra. And as a healthcare provider, I am as happy that his doctors are doing good service. So it's a near 10% stakeholder satisfaction. What more can we expect? So these are my thoughts on how we can forge ahead and leapfrog Maharashtra on these parameters, which are not so promising at this juncture, but I'm sure there's light at the end of the tunnel, as they rightly say. And I thank you all for having given me a patient hearing. Really.
Thank you, sir, for a very informing presentation on some alarming facts and some success stories, as well as the way forward to improve the healthcare system in Maharashtra.